first one. So we've got a 35-year-old chap who attends your clinic with his 30-year-old partner. They've been trying to conceive for 2 years unsuccessfully. There are no female gynecological factors. What are the most important features to elicit from the clinical examination?
So is this a clinical examination of the male?
Yes.
So on clinical examination, I'll perform a general examination to assess the BMI and also to ensure that the patient is well androgenized. I'll examine the external genitalia, so noting whether there's noting the presence, location, size and consistency of the testes and any palpable masses. I'll look for the presence of varicocele. I'm sure see if the epididymi are palpable and if they feel full, or the presence of any epididymal cysts. I'll see if the vasa are palpable. And I'll also look for any previous surgical scars in the inguinal regions.
Okay, so when you examine him, he looks like he's appropriately androgenized. He's got normal volume testes bilaterally, and he's got a palpable vas and epididymi bilaterally as well. What investigations are you going to organise?
So I will arrange for him to provide a semen sample for semen analysis, and also a serum hormone profile measuring the testosterone, LH, and FSH. Okay,
so his semen analysis, have you got a pen?
Yeah.
He has normal volume at 3 mils, but there's no sperm, and he's got normal FSH. What are the possible diagnoses?
So he has azoospermia, but it's normal volume, so it's most likely to be a non-obstructive azoospermia, especially given the normal clinical features as well. And these could include genetic abnormalities.
So what type of azoospermia do you think he has?
So based on the fact it's a normal volume, he's got normal clinical findings. Mm-hmm. So actually, I'll say actually it could be a obstructive azoospermia.
Yeah, it's more obstructive. Okay, so what investigations are you going to do next for obstructive azo?
So in order to identify the underlying cause, I'll arrange for him to undergo an MRI scan of the pelvis to look for evidence of, for example, ejaculatory duct cysts. And I'll also arrange for an ultrasound scan of the testes and scrotum to determine if there's evidence, for example, of epididymal cysts. And I'll also arrange for him to undergo a transrectal ultrasound to determine if the seminal vesicles are significantly dilated.
Is there any point in doing a truss and an MRI? Provide you different bits of information?
Actually, no. So an MRI would be less invasive, and would the seminal vesicles can still be imaged on MRI.
Okay, so which one are you going to do?
MRI first.
Okay, so his MRI and his ultrasound are both normal. What are you going to do next?
So in this case, still haven't identified the cause of what his obstructive azoospermia could be, and I would re-exam ensure as all there's no neurological symptoms of the patient suffering from, I'll request an STI screen to rule out, for example, any underlying potential epididymitis. But in terms of...
Is that likely in this patient?
No, sorry, it's unlikely. So I'll counsel him about further options to achieve fertility.
No. So are you going to do any more investigations on this gentleman?
It's I think apart from the Azoospermia, I'll request a further semen sample.
It shows the same thing.
And
okay,
I don't know.
You can say no if so you started to talk about counselling him. So what are you going to counsel him about next?
So I'll explain to him that in order to achieve fertility, so in order for them to achieve pregnancy, that the most likely means would be assisted conception techniques, and this would be through surgical sperm retrieval. Given that this is obstructive azoospermia that we're dealing with, then these would either be in the form of percutaneous epididymal sperm aspiration or a microscopic epididymal sperm aspiration.
Which one are you going to do? Which one would you recommend?
So I'd recommend that he undergoes microscopic epididymal sperm aspiration because it deploys microscopic analysis at the time of surgery, allows for any viable sperm to be identified, and is associated with a better outcome in terms of sperm retrieval.
Okay, and what are the other techniques that you're aware of?
In terms of surgical sperm retrieval, I'm aware of techniques relating to the testes. So there's teaser or testicular sperm aspiration. There's TZ, which is testicular sperm extraction, which involves taking samples, making incisions through the tunica albuginea, and taking samples of seminiferous tubules. And there is also MTs, Microteasing, which involves bivalving the testes and opening of the seminiferous tubules and attempt to extract viable sperm from them directly.
And when would you use each one?
So the testicular techniques I would use where there is non-obstructive azoospermia. And in terms of underlying conditions such as Y chromosome microdeletions and Klinefelter syndrome, then Microteasing provides the greatest success of sperm retrieval, and it's the only technique funded for these particular conditions.
That's not quite true. So what are the advantages and disadvantages of a TZ versus a Microteasing?
So a TZ is performed, in terms of operative time, it takes less time. There's lesser need for an embryologist. There is less kind of direct trauma to the seminiferous tubules, less chance of bleeding. The disadvantages of TZ are that because the tubules are not being examined at the time, it's variable as to whether or not there'll be any viable sperm. A Microteasing would allow, for example, for small pockets of sperm to be identified, and therefore for a more accurate means of surgical sperm retrieval.
Okay. How do you perform a TZ and how do you perform a microteasing?
So for both procedures, patient will be appropriately consented, prepped, and anaesthetized. Both involve midline scrotal incision, delivering the testes. With a TZ, multiple small incisions are made in the tunica albuginea. The seminiferous tubules are squeezed through to the surface, and protruding seminiferous tubules are then excised. Whereas with microteasing, again, incisions are made in the tunica albuginea, but using microsurgical techniques, the seminiferous tubules are magnified, opened up, and sperm is aspirated and then analysed under the microscope to look for the presence of viable sperm, which can then be used for ICSI.
Okay. Okay, that's the end of the scenario. So you could, with obstructive azo, you could also do a vasogram if the imaging is normal. It will just image the VAS. That's what you're really looking for. Because if you've already done an MRI, you know that the 7F, what's it called, the SV looks normal on the MRI, but it will, when you do a vasogram, you will get contrast in the SV as well. It will image the whole of the ejaculatory duct. And what you're looking for, any sites of obstruction. But, arguable that you need to do that very often. The MRI is probably good enough to look for any abnormalities. The different techniques, so you're a little bit muddled, so I'm just going to run through them really quickly. So Emeka said this as well. So if you think about the good techniques for surgical sperm retrieval, they're the techniques that urologists do, and they're T's. Yeah. So that's either a microteasing or a TZ. A TZ, you do need an embryologist. Ideally, for all surgical sperm retrieval, you need an embryologist in theatre. Ideally, that's really the gold standard. It's not always possible, but that's the gold standard. A TZ, it's obstructive azoospermia. So these guys have about a 70% chance that they will have sperm in the testes. But there's a blockage somewhere along the way that's stopping the sperm from getting out. And that can be intratesticular obstructions as well. So that might be why your imaging is all normal, but they've still got clinically an obstruction. So that's an obstruction that's not amenable to reconstruction if it's within the testes. So you basically deliver the testes, and stab incisions in a couple of points was the classical teaching, but you could probably do it in one spot. That's what we used to do at UCL, because the chance of them having sperm is so high. So you could do one spot, one stab incision in the tunica, express the seminiferous tubules, just cut it, give it to your embryologist, who will say, hopefully, yes, this sperm, and then take it off, and then it will be used for ICSI. IVF. The microteasing, again, you deliver the testes, you bivalve the testes, you do one side at a time, bivalve the testes, bring your operating microscope in, and you're looking for areas where the seminiferous tubules look plump and moist. And those are areas where there may be sperm, and you'll harvest those areas. You'll give a small specimen to your embryologist, who will say yes or no. If it's a no, you look for some other areas which look promising. If it's a yes, then you might take a bit more from that area and maybe even try some other areas as well. All done under the microscope. You end up taking slightly smaller specimens of the testes. With a microteasing, that's the gold standard for non-obstructive azo. Or for the small portion of patients where you've done a TZ and they've got obstructive azo, but that's failed. And they're both funded on the NHS. The other techniques, the one the gynecologists like to use is a PISA or a TISA.
Yeah.
A PISA is where you'll try to aspirate sperm from the epididymis percutaneously, and that relies on the epididymis being dilated. So if the epididymi are not dilated, you can't do a PISA because, have you tried putting a needle into the epididymis before?
No.
It's all flat. It'll be impossible. Your needle will go through the back wall. The downside of that is that you can cause local inflammation around the epididymis. So you do a PISA if there's obstruction, the epididymis is up, dilated, I mean. If you do that and they've got subsequent inflammation, it may make any reconstruction more difficult or impossible.
Yeah.
So urologists generally don't like that technique. The other technique that gynecologists use is a teaser, and that's essentially random stabbings of the testes through the skin. Because obviously gynecologists don't operate on the testes, so they're not going to deliver the testes. So they do it through the skin. It's all random stabs, and you aspirate and try and see if you can get some sperm up. Again, we don't like that technique. It just feels a bit like you're throwing a dart in the dark and hoping for the best. So we generally don't use either of those techniques for the most part. A teaser, you would use that if there's obstructive azo. And the last technique is a MESA, and that's the technique you would do at the time where you're doing a vasectomy reversal. So you've got the two cut ends of the vas. You're hoping that you're going to be getting some fluid out of the testes end of the vas. You aspirate that fluid, you give that to your embryologist because you're hoping that there's sperm. Because if there's no sperm in that fluid, then it's a bit pointless doing a vasectomy reversal because nothing's going to be coming out anyway. So it's a waste of time. But it's also insurance, because if you do a vasectomy reversal, they might be patient for a period of time and then they may stricture back up. But at least you've frozen some sperm from that specimen that you took out.
Yeah.
Make sense?
Yeah.
So those are the different techniques and when you would use them. They're all funded on the NHS for the appropriate patient.
So essentially, I think for the exam then, for both obstructive and non-obstructive, it would be TZ and Microteasing.
Yeah.
And in terms of the ones that aiming at, we talk about aspiration, epididymal and testicular aspiration, that's the ones that non-urologists do.
Yeah, but you need to be aware of them. Urologists will do a MESA at the time of a vasectomy reversal, but the TESA and PISA we generally don't use, but you do need to be aware of them because they are techniques and patients may ask you about them. So you might need to be able to tell them the pros and cons, when you would use them and why you wouldn't want to use them.
Yeah.
Yeah? Any questions?
No, I don't think there's any further questions. I think, because I suppose in terms of determining which type of azoospermia it was, I was thinking, relying a lot on examination findings of there, for example, being something there, whether it's an impalpable vas or a dilated epididymis. But I suppose if everything's normal, examination-wise, and the hormone profile's normal, then
it's obstructive. It's
more likely to be obstructive.
Yeah. So generally, if you see somebody who's got non-obstructive azo, they'll often have Klinefelters. That's a good question to throw into this part of the exam. So if they tell you that you've got a Klinefelter's patient, the scenario is going in one of two ways. They're either going to ask you about hypogonadism, or they're going to ask you about somebody with non-obstructive azo. You can almost predict it. There isn't anything else they can ask you if the patient's got Klinefelters. Yeah. With obstructive, they will have a good volume testes because everything is normal in obstructive azoospermia. So the testes is working normally. They've got normal hormone profile. axis. So you're expecting everything to be normal, but their semen analysis, they've got azoospermia. With non-obstructive, they'll have small testes. That's classically what you'll find. Small, soft testes, their FSH will be up.
Yeah.
Their testosterone might be normal or low normal or borderline. And if they've got Klinefelters, it might be low as well. You also mentioned about Y chromosome deletion, microdeletion at some point. You would want to do genetics on any patient where they've got azo, especially mainly if it's non-obstructive azo, or if they've got very, very low oligospermia, like certainly less than 5 million, you'd want to do a genetic score, because there is a risk that they'll drop off to zero if it's that low when you initially see them and they're already struggling to have children. Yeah. If you wait a year, a proportion of them will be azoospermic within a year. So the genetic profile you want to do is CF, because that has consequences for the family. Because if both partners have carriers for the cystic fibrosis gene, then they've got a 25% chance that if they have a child, their child will have cystic fibrosis. And that, that's a lot of work. And therefore, the parents need to be aware of that. The second thing you're looking for is karyotyping. That's where you'll pick up Klinefelters or other genetic numerical abnormalities. And the third thing you're looking for is the Y microdeletion, because if they've got microdeletion A and B, there's a 100% chance that you will never find sperm. So there's no point doing any surgical retrieval. If it's C, then it's a 50% chance. Yeah?
Yeah.
Make sense?
Yeah. So for this patient, because he had azoospermia, should he have been offered genetic?
Probably, yeah. Probably. But because it's non-obstructive, I don't think you would fail by missing it out. But I think in my clinical practice, I probably would offer him genetic testing for azo. And I think the guidelines would suggest that he should have genetic testing as well.
Yeah.
Make sense?
Yeah. Thank you.
That's okay.